Good morning, everybody. Welcome to the webcast that we're holding today on advancements in AML in Atlantic Canada. We will begin the webcast in about 2 minutes, so just hang tight with us. Good morning, everyone, and thanks for joining us. We will be starting our webcast in about 1 minute. Thank you. Okay, everyone, we're going to get started. So welcome to the Leukemia and Lymphoma Society of Canada Atlantic Regions event, Advancements in AML in Atlantic Canada. In this webcast today, we'll be joined by Dr. Mahmoud Elsawy, who will discuss advancements in AML research and treatment in Atlantic Canada. Before we begin this morning, I'd like to introduce myself. My name is Trudy Dyer, and I'm the Regional Director for the Atlantic Region with the Leukemia and Lymphoma Society of Canada. I will be your host of this online event today. The presentation will last approximately 60 minutes, and it will include a question and answer period at the end. Since there are many of you here today, we invite you to please type your questions and comments in the Q&A box in your Zoom webinar panel that you'll see at the bottom of your screen throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation during the question and answer period. The conference today will also be recorded, therefore you can listen to it again on our website. Before we begin our main presentation, I would like to share with you our mission and highlight some resources that might be helpful for you or someone you know. So if we can go to the next slide. At the LLSC, our mission is to cure blood cancers and improve the quality of life for those touched by a blood cancer and their families. We offer guidance and support at every step of the way. Go to the next slide. We know that the current situation presents many challenges to those that are affected by blood cancer and their families. The community services managers can help. They are compassionate connectors that can help those affected by a blood cancer cope with anxiety and isolation during these times. Please do not hesitate to contact a community services manager in your area. We can go to the next slide. We know the current situation does present challenges, as we said, and we offer a variety of educational resources and support services to help those affected by a blood cancer, including AML. For example, on our website, bloodcancers.ca, you can access free booklets and fact sheets containing information about specific blood cancers, treatments, and practical information, as well as a new AML educational video. Go to the next slide. Visit bloodcancers.ca/webcast to watch the recordings of all of our past webcasts and view announcements for our upcoming webcasts. You can also subscribe and listen to our podcast series, The Blood Cancer Experience, to learn more about treatment and research and to hear stories from people affected by blood cancer. They're available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your favorite podcasts. Our peer support program is a support service that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and have shared similar experiences. Whenever possible, participants and volunteers are matched based on their age, gender, and their diagnosis. It can be a useful program, especially these days, to help counter the effects of isolation. We're now going to get into the main part of our presentation, and it's my pleasure to introduce today's speaker, Dr. Mahmoud Elsawy. Dr. Elsawy is an associate professor of hematology, an attending hematologist and transplant physician with Dalhousie University and the Nova Scotia Health Authority, and affiliated to the Fred Hutch Cancer Research Center in Seattle. His research focus was around the impact of comorbidities on outcomes of transplant recipients, treatment of AML in the elderly population, and survivorship following bone marrow transplant. Additionally, he has special interests in management of myeloid malignancies in older adults and in providing immune effector cell therapy. An example of that would be CAR T cell therapy. Dr. Elsawy is the lead for management of AML and the medical director for establishing a regional IEC therapy program in Nova Scotia. Thank you for taking the time to be with us today, and Dr. Elsawy will go over to you.
Thank you so much, Sri, for the very nice introduction. And again, thank you for the Leukemia Lymphoma Society for the invitation and for really being there supporting our patients at all time. And at the end, it's a big thank you for our patients who are really the driver behind what we do. And we hope we can make some positive differences in their lives. So with that, we will get started. And I just had one just note. I'm an assistant professor, so not associate. Like that's a good really sign that because I will be applying for associate soon. So thank you for giving this future glimpse. Today we will really focus on some issues around survivorship versus survival mode, and I will promise you this will make sense in a few minutes, with some focus on advancements in AML in Atlantic Canada and what new drugs and new approaches we have for our patients. So these are my conflicts of interest. None of this will be relevant because we're not talking about any specific recommendation or drug here. I would just like to start really with an acknowledgement for someone who you really most, if not all of you know, Dr. Kuban, uh, who was a pioneer in Canada and internationally in the field of treating blood cancers in general and leukemia and stem cell transplant in particular. It's really the impact that those pioneers left behind, which we built on to improve further management of our patients. I was privileged to work with Dr. Kuban for a year before his unfortunate passing in 2019. So the objectives of our talk today is to describe the burden of post-therapy morbidity among survivors of AML, highlighting some potential early prediction models, especially those who include comorbidities and some of the work we did in Atlantic Canada in this regard, and just showing some examples of how this could be utilized to further alleviate the resultant morbidity or diseases that really comes with the treatment of AML, and how the future of AML therapy in Atlantic Canada looks like. So just as a background, AML is a disease mainly of the elderly. So the median age at diagnosis is 68 years. That means more than half of patients will be 60 and above at the time of diagnosis. So that poses lots of challenges really, which comes with treatment, which is quite intense, as we will see. So in Canada, and this is adapted from the Leukemia Lymphoma Society, and this is kind of a pie showing the distribution of leukemias. And if you see here, 24% of all leukemias are acute myeloid leukemias. So it comes the second most common leukemia after CLL or chronic lymphocytic leukemia, which is the most common subtype. So we really have a lot of patients and a lot of varieties, because it's not just one disease that we need to take care of. So if we look at the figures for 5-year survival and how we did over the years, the green line down there, this is the acute myeloid leukemia. And if you look over the years, and this is from Canadian database, there was steady, slow, but steady improvement in outcomes, going almost double from 10% or little over 10% to little over 20% of survival at 5 years. That's all patients. So we have better results in specific subgroups and in specific age groups, but that tells you that we still have a lot of room to improve on the outcomes, and we already made improvements over the years. And I will let you know at the end why the improvements were slow and why we are expecting that this will go exponentially higher over the next years. So let's start with like just some description of what is survivorship, or what are the phases of survivorship. So cancer survivorship really starts at the time of diagnosis and during the immediate period after treatment and throughout life afterwards. So it includes family members, not just the patients really, friends, caregivers, who are all key players in making this survivorship successful. There are three main phases of survivorship. Acute survivorship, which means the period when patients are still dealing with the diagnosis, getting to know more about their disease and how to treat it, and dealing with the immediate side effects of treatment while they are getting the treatment. Then comes afterwards the extended survivorship, which is a few months after the end of treatment, where still there are some effects of treatment that are still impacting patients, and a lot of anxiety about the disease coming back, which could last for even a year or two. Then the permanent survivorship, where you really need to rehabilitate patients just to get over the side effects of treatment, get over the anxiety of having the disease back, and just be back to their normal or near normal for the rest of their life. So if we look at phases of survivorship and apply it to AML, so we start with a diagnosis, and then patients, according to several factors, could receive intensive treatment or high dose treatment for induction, that's what we call it, or non-intensive treatment. And afterwards, they can either receive a transplant. I'd say majority of patients receive transplant, so you will come across a lot of transplant studies as we move forward, or no transplant. Then after transplant, patients could get something called chronic graft versus host disease, which is another set of diseases really that could really accumulate very fast, leading to another sort of morbidity, not just the AML, but other set of diseases, or no GVHD. Then there are patients who receive maintenance treatment or no maintenance treatment. So it's really a journey, a long journey, lifelong, I'd say, and throughout which patients move from survivorship, survival mode, and as they move forward from one treatment to the other, this is the survival mode where there are the short-term side effects, and then there is the survivorship, which is later on try to rehabilitate patients and merging them back to their normal or near normal life to pre-diagnosis. So just to make it more easy to understand, and if you guys remember, the movie Castaway, and this is a survival mode, and this is when you live for a day by day, and you get excited with the new achievements you make every day, and this is what I would consider a survival mode. But if you look at survivorship, on the other hand, that's when you already got over the phase of treatment and now you want to get back to your normal life to start again from where you stopped before having this diagnosis. And a key here, and if you guys remember the name of this ball in the movie Castaway, his name was Wilson, and Wilson here was really the caregiver who was there even though it was just an imaginary caregiver, but caregiver is very important throughout this journey from survival mode to survivorship. So with that, the outlines of this talk will be just going quickly over the pillars of post-therapy survivorship, which are the health-related quality of life, health status and health behaviors, disease status and caregivers, how the interaction of all these factors lead to transitioning patients successfully from having a disease, which is very serious, to going back to their normal life. Some examples of models to predict the long-term consequences and select preemptive interventions to target complications and some evolving concepts in the therapy and current and future new AML therapies. So to start with the pillars of survivorship. So really survivorship is the interaction between quality of life, disease status, and health status. And here, a new emerging area that we need to really identify and acknowledge are the caregivers. Health status is defined by the WHO as a state of complete physical, mental, and social well being, not just the absence of disease and infirmity. So it's really broader than just having no disease, it's a complete set of just being well. So a lot of factors here impact this health status from genomics, phenotypic expressions, functional condition, mental condition, and health potential. So the health-related quality of life, which is quite even more specific than just the health status, it's personal and very subjective, and it depends on many factors and many values really that are very personal and very patient-specific, impacted by political, societal, environmental, familial, health system factors. And the health related quality of life is the impact really of interaction of health care, illness, and treatment on quality of life. So just some example of long-term consequences of treatments, and I'm not gonna go through a lot of slides. I promise you I will leave more time for questions, but just highlighted two main long-term effects that come with really any type of chemotherapy, and more so with treatment of AML, which is quite intense, including transplant. Fatigue, it's not uncommon for patients to have fatigue after getting through all this treatment, and it's a state of persistent feeling of physical, emotional, mental tiredness or exhaustion. So it's basically feeling drained for no good reason, and this is the most common side effect of cancer and its treatment. It could persist for months or even years after finishing treatment. It could really affect the daily life and quality of life, and it does not match with the level of activity, meaning that patients could really be doing little but still getting exhausted very quickly. And it does not improve with rest, which is another characteristic of this cancer related fatigue. We're still learning about this phenomena and how to treat it, but are there biologic mechanisms, especially in AML populations, that could be underlying this fatigue? The answer is yes. There are correlations between lots of biomarkers, and these are all biomarkers specific for AML that goes up and down with this disease, and the quality of life scores after treatment. And the correlation is quite evident even when you apply lots of quality of life measures. So that's the first step to identify the problem, is to find out where is the problem and then how to fix it. So there are lots of ongoing studies really trying to tackle some of those biomarkers, because like if you want to imagine it's simply creating a state of persistent inflammation in the body. All those biomarkers are associated with inflammation that keeps people feel always exhausted, because if you have ongoing inflammation in your body, that's a reaction of the body just to give you some rest. So we are still learning more about this, but we know it does exist. It is real. It's not something psychological or emotional. It does have some biological background as well. Another common side effect, which is neurocognitive side effect, or as people want to call it, the chemo brain. This is the second most commonly reported long-term side effect of AML treatments. Prevalence really is in keeping with studies in other types of cancer, so it's not just specific to AML, but again, maybe more pronounced given in AML, given the nature of the treatment, which really extends over long periods of time, mostly intense treatment. There are several proposed mechanisms. Again, we are still learning, but some of the mechanisms include like minor damages to the DNA in the central nervous system that might not lead to a clear pathologic neurologic event, or like paralysis or loss of memory or something like that, but just small things that could lead to this called chemo brain or fog. I feel slow, or I'm not back to my normal before treatment. So it also is real, and it does have some mechanisms that we are still learning more and more about. Health behaviors, and I just want to here highlight this because it's really important, because when they did studies about screening, and I mean regular screening for AML patients after they finished their treatment for other health related conditions, it was shocking that 83% of patients did not receive the recommended screening for other cancers. Like, having one cancer doesn't mean you are immune about having other cancers, not just one cancer per lifetime. Still, patients are at risk of actually developing more cancers down the road. And there was a great misconception that 67% of patients, when they were coming for the regular appointments for blood work, they were under the impression that they are being checked for other health issues as well, which is not true, because for example, for stem cell transplant recipients, all the investigations we do, or most of it, are just directed towards detecting the leukemia, detecting graft versus host disease. But still, patients need to be vigilant about, let's say, their colon cancer screening, their skin screening, their oral health, a lot of things that are misconceived as being done when they come for their appointments, while it is not. You still need to just focus on the other things equally as you focus on your AML, which is now gone. So just very briefly as well about caregivers, or what we call them co-survivors. So this was a Canadian-led study done in collaboration with Seattle, led by one of my colleagues, Dr. Jamani, who is now in Alberta, leading really a great work around survivorship and long-term survivorship for patients and their families after transplant. And they really asked like a very simple question: how does the quality of life of caregivers of transplant recipients look like? So it shifted really from focusing on the patients towards shifting just a glimpse on the caregiver. How does this population do? Because it was really never studied before. And interestingly, they did find like 1 in 5 of caregivers reported poor quality of life versus the general population. That's huge. That 20% of caregivers are suffering equally or to a lesser extent with their patients. And they found this really affected a lot by age, gender, education level, which are quite important predictors of how the quality of life of those caregivers looks like. For example, females tend to suffer more. Those who are caregivers at an older age used to suffer more. Those who have less level of education used to suffer more. Things that make sense, but it was never studied before. And this was a very, I think, first to my knowledge, study that highlights and or sheds a light on this very relevant question. And there was higher prevalence of depression and sleep disorders among caregivers versus the general population. So these are just some of the comments which were posted back when caregivers got the questionnaire, and really it's very touchy. Like a caregiver said, when I heard you were doing a caregiver survey, I thought finally someone cares. Those caregivers, they are really like silent sacrificers. They don't get a lot of attention compared to the patients, but they equally suffer, sometimes even more than the patient, especially if they are a parent or a wife. They tend to suffer more. And this is another touching comment from a caregiver where he or she said there are times when you want to say, I'm done, but you have to keep going for your loved family member. So let's shift gears a little bit, and this is some work which I was part of when I was in Seattle, looking at really developing uh, a novel model that does have like all have input from pre-treatment health status of patients, comorbidities, let's say the other diseases that a patient have pre-treatment, together with the risk from their acute myeloid leukemia and other factors, and whether or not this does impact how they do when they receive the intensive treatment. It was not studied systematically before that study, and interestingly, in a large set of patients, we did find this AML comorbidity model does really identify very clearly different groups of patients who does from very good to very poor, and those are the ones who have less comorbidities or a better health status going into the treatment of AML, down to those who have lots of health issues going through the treatment of AML. Again, it makes sense, but it was not studied combining all of factors in a single model before that. So
the
what we
prognostic validity of the acute myeloid leukemia composite model.
so what we did here, and I'm sorry
This is
this
what
I didn't remove the recording here, but we did look at this in Atlantic Canada among our patients, and this was done by Dr. Murphy, one of our senior residents, and we got patients represented from three centers, from our center and from two Newfoundland centers, and we looked at whether this model could predict the 1 year mortality among our patients. The same model we applied here in our Atlantic Canada patients, and that's what we found. Yes, it does, and it does do clearly as well as the original model. And we came with a conclusion that this is a valid prognosticator for early and late mortality in our patient population, and assessment prior to induction is important to really counsel patients and tell them objectively this is what might happen and these are the chances in an objective manner, and giving numbers is really important, particularly when you are still heading towards something that's totally new to you. So
we also identify
sorry about that. So then we are trying to implement this preemptively. It's not just we have a problem and that's how we define it, but our goal is how to really prevent it from happening. And that includes really targeting those high risk patients and high risk comorbidities with interventions uh, before or alongside the treatment of leukemia. Like, for example, we know that patients who have lots of history of heart disease or diabetes or whatnot, when they start treatment of acute myeloid leukemia, they tend to suffer more during the treatment and afterwards. So how about we try to optimize their heart condition before we even start treatment, or make sure that this is closely followed by a cardiologist, for example, during the treatment, whether this will improve their outcomes after the treatment. That's our goal. So it's not just really to identify the problem, but to try to use the information to preemptively prevent future problems. So this is a nice work which was done in Vancouver, looking at implementation of exercise program, physician prescribed exercise program for patients and later then survivors of transplant, given that transplant is really a major part of treatment of AML. It was a prospective single-arm study, just simple 12-week partially supervised exercise program, and it did test endurance, stationary bike, walking, really simple things that could be available in any ward that treats hematology patients. Primary outcomes, they looked at the feasibility and retention. They looked at different time points, that's T, time point 0 before transplant, then compared at discharge, and then compared at day 100 after transplant, including several variables, quality of life, muscle strength, mobility, etc. And they could recruit 43 consecutive patients. 70% entered the study, and overall retention was 80%. So to look at the outcomes and just to simplify it, the grip strength at the time of discharge, and if you look at the difference here, it went from 25 to 28 kilogram after this exercise program was implemented. And time up and go in seconds again went down, because that means like patients are getting up and down faster at day 100 after applying this exercise program, with other endpoints that also significantly improved before and after. So this does mean that exercise alone, a regular exercise alone, could really mitigate the negative effect of the chemotherapy and transplant in terms of fatigue and performance. And here in Nova Scotia, we have this ACCESS program, which is activating cancer communities through an exercise strategy for survivors. And this is from the website of NSH Cancer Care Program. And this was really very helpful program, which I personally sent some patients for it, and they were amazed by how well organized and how benefit they received when they participated in this simple program. Of course, now with COVID, things changed, but still they are working. And whenever I get a chance, I have the flyers, I hand it to the patients, and they call the personnel who are really very dedicated to this program. And you can get the program, you do it at home. I find it really very positive program that did really impact some of my own patients, and I could see that it will continue to grow, and hopefully we'll have it extended all along Nova Scotia at some point, or all along Atlantic Canada. So just to give you a quick glimpse of how we used to treat AML and how we are going to treat AML, if you look for 20 years, and this is since 1973, we had just one regimen for treating AML called the 7+3, 7 days of a treatment called cytarabine, followed by 3 days of another treatment called daunorubicin. And this didn't really change. There has been virtually no improvement on this for 20 years. And finally, in the past, few years, really, because all of the advances, most of it happened 2017 and up. But there was another drug came in 2002, another drug that came and was withdrawn again, gintuzumab in 2000. But really the most advances happened in the past, like let's say 5 years, where we have limtuzumab came again, a drug called CPX, enasidenib, and midostaurin, gilteritinib, venetoclax, glasdegib, ivosidenib, azacitidine maintenance, and these are only the approved drugs. So we didn't even talk about drugs that are still in clinical trials, but that tells you that we are experiencing now a very steep rise of the curve, and that makes sense now when I said like our outcomes were going up slowly, but really the difference was not that great. And when I'm telling you now outcomes will really improve exponentially, and it will double by every few years, that makes sense because we just have now lots and lots of options, which makes the treatment more personalized, if you wish. So now there's a new approach really among the FDA and Health Canada, which is called the patient-focused drug development. It's an approach really to systematically include patients' experience through gathering data on the approved drugs. And this is simply called PROs, or patient-reported outcomes. Patient values of what they need may be quite different from what the drug makers want. Like patients might really value a good quality of life in compromise of a quantity, or the other way around, which might not really align with the drug makers who always look at just survival, for example. So this new approach is really to integrate patients and their experience. And if you look at all drugs, or most of the drugs that are currently being approved, there always be a section on the patient-reported outcomes or patient-reported quality of life, which is equally important as the efficacy of the drug when it comes to assessing the profile, whether this drug could be approved or not. Just a hint about the new drugs we have or we will have in the future, CPX351. This is similar to the 7+3 cytarabine and daunorubicin, but now it's instead of having two different drugs injected at two different times, this is just one molecule included in one, let's say, liposomal capsule with a fixed ratio. So you really have a control over what exactly goes to the patient, and it's a very promising agent. And the interesting thing about this drug is that it was developed in Canada, in Vancouver actually, and now it just got approval to be used in certain types of leukemia. Another combination, which is really very promising and coming in Canada, it's now approved in the States, which is venetoclax combined with azacitidine or decitabine, these two drugs. And this is mainly directed among patients who cannot receive intensive treatment for one reason or another, whether they are older or they have other health conditions that makes toxicity of or side effects of the treatment really outweighs the benefit expected from the treatment. Before that, we didn't really have great options for those patients, but now this venetoclax-based regimen is really very promising, and it is approved and got approval in the States and got positive feedback in Canada, but not yet available on a large scale. And just one concept here called maintenance, and I use transplant as an example, but if you want to understand what maintenance means, if you look at the three graphs here, or the three curves, this is time and this is the disease status. if you go down to a state of what we call undetected disease, but still down the surface, it will stay down for a while, short while, but it will come back. So how about if you go further down, and that's what we call when you have like minimal disease, and as you go further, the disease will stay down for longer time to the point that if you can get it really down that is not detected at all, then the disease will never come back. This is the concept of maintenance. And for years and years and years, this was tried in AML and really never proven efficacious for lots of various reasons. Lots of agents were trialed till this agent came last year, which is oral azacitidine maintenance for AML in first remission. And this was kind of a breakthrough because for the first time, there was a significant survival difference of 10 months between those who received the maintenance after their treatment versus those who did not receive this treatment. All the studies before then didn't really find any difference. That's why the concept was there, but really never translated to a clinically meaningful difference. But this was the first study to show a meaningful difference for those who received maintenance. And without going through many details of the study, but really the quality of life was very preserved. It was an oral agent, so patients was getting this treatment as an outpatient. And we have this now on a special program available in Atlantic Canada. Just a look at the future, and this will be a study that I'm hopeful to open here. It's a sponsored study from the company in the next few months, but it will look at another interesting agent called magrolimab in combination with azacitidine versus venetoclax, azacitidine, or intensive therapy for a group of patients who we really know treatments or conventional treatments do little for them, which is the TP53 mutant patients. So simply, our body or the cancer in general is very smart. So macrophage is an immune cell, and our body could defend us against cancer to an extent using our own immune mechanisms. So this macrophage could identify the cancer cell and kill it, but the cancer cell does have this CD47, which is a do not eat me signal. So the cancer cell has two signals: eat me signal, so which tells the immune system I'm foreign, I'm cancer or dangerous, just eat me. But then the cancer cell also is very smart, which and expresses the CD47, which blocks this eat me signal or tell it don't eat me. So it is blocked, so it can see the cancer but can do nothing about it. So this agent really blocks this do not eat me signal. So now all what is left is the eat me, and the macrophage can eat the cancer cell. So it's another way to harness our own immune system towards our own good. So this same graph, and as I told you, for 20 years, we didn't have a whole lot, but in the past five or 6 years, we had lots of agents. So what do we have currently available in Atlantic Canada? We do have this oral azacitidine maintenance through a compassionate program, or what we call a special access program. We do have a gilteritinib, which is for a particular group of patients who have this FLT3 positive mutation. We have gemtuzumab for newly diagnosed acute myeloid leukemia patients. Midostaurin, again another agent for FLT3 positive new AML patients. CPX for a group called secondary AML. We have this trial of magrolimab, which is very soon to open. And I'm conducting a trial which is still in the works for looking at a better consolidation schedules for patients with AML, and this will be a randomized trial still underway, but it will come up very soon. looking at a different schedule, like we used to give this consolidation therapy. Those of you who received consolidation know we used to give it over 3 alternative days, or a total of 5 days of hospitalization, or sometimes even more. So we are looking at whether or not it will be safe and effective to give it just consecutive days, 3 days instead of 6 days, and how does this impact the quality of life. So again, it's a very patient-centered, and we hope we will be able to launch it here in Atlantic Canada very soon, just for the good of our patients as well. So just very, very briefly about a new drug that will be hopefully available soon. It's now available, CAR T cell therapy, but for acute lymphoblastic leukemia and non-Hodgkin lymphoma. Still ways to go for AML, but the future looks really very bright. And this is just an example. The FDA clears, and this is an investigational new drug, this IND application for a novel treatment to treat advanced acute myeloid leukemia. So we don't really have a drug yet that's approved in this category for AML, but I just thought to give you an idea of how the future will look like and what is really the concept behind this. So in this CAR T cell therapy, it's really, again, another way to improve the mechanisms that we already have in defeating cancer towards our own good. So we do have mechanisms that can prevent cancer from even happening or control it when it comes. But the cancer is also very smart that it could evade those mechanisms. So really our target now, and this is shifting over the past years, is away from just trying to push more and more toxic treatments towards trying to get our immune system back to be even smarter than the cancer and try to attack it. So simply, it's taking those T cells, which is a very important component of our immune system, and take it to the lab and make it very specific, or give it some weapons, let's say through inserting a gene. So now it can identify the cancer specifically through this chimeric antigen receptor, then grow it in millions, infuse it back, and it goes in a kind of search and destroy just for the cancer. Of course, this is very simplified. It's more complicated than that, but this is just how it works. So back when we used to have a patient with AML, really all what we have is just one line, goes like through 7+3, and then consolidations and transplant. This is just to tell you, and these are the guidelines which we recently developed in Atlantic Canada just a couple of weeks ago for patients who are above 60 with AML. Look at the algorithm, it's really getting huge with lots of choices, and it's very personalized that whatever can work for a subset of patients might not be the best for other subset of patients due to several reasons, mainly based on genetics of the disease, what we know more about the disease. Now we used to have this what's called next generation sequencing, which is a deeper dive into the molecular markers of the disease, which really could tell which treatment is expected to work better. So back when I started treating AML, I don't know, like 2007 or whatever, we used to just have one size that fits all, this 7+3. Now the choices are just getting more and more, I'd say by the month, and it's really more towards personalized approach towards this particular disease in this particular patient. So I want to finish up with that. This is the importance of patient education in transplant and what patients really valued they had known before transplant about the quality of life. And interestingly, patients really, when they had this questionnaire, a lot of them outlined that they didn't really value much of what they heard during the transplant consult because they were more focused about like getting rid of this disease right now, and they didn't really retain a lot of what could be the long-term consequences, in particular to quality of life, till it happened really years after. So they valued if they could have had a better education just to be mentally prepared for what the future could bring to them. And this is again a new approach that we are using, is just engaging patients more and more into the discussions, asking questions that could reveal whether like patients really understand the consequences of the decision, or really understand all the dimensions of the treatment they are going to receive or not. So with that, I would just summarize here, like AML therapy has significant consequences on patients and their caregivers, both physically and mentally. And survivorship scope is really wider than just monitoring the disease and preventing relapse. Early intervention, as I showed you, in those who have vulnerable group with targeted interventions may be feasible to make the treatment more effective and less toxic, making the quality of life better. Caregivers are very, very important when it comes to this survivorship equation. They are essential and we can't really ignore them. We need to engage them more and more. And there are new and new emerging therapies that might really make the treatment of AML more chronic, extending over longer periods of time. Let's say, for example, the maintenance is forever, or until patients really don't want it. So it's shifting gears a little bit from a disease that has very acute presentation, needs very acute toxic treatment, to maybe a disease that could be managed with small doses of chemotherapy as an outpatient for longer periods of time. So future challenges and unmet needs, education for patients and their caregivers is vital. I think we are doing better in that regard. Leukemia Lymphoma Society is a great example of this initiative. Whatever we are having right now is a real example of this education initiative, improving the healthcare practitioners' awareness of the needs really of patients in terms of their survivorship will improve this relationship. It's not one-way relationship, just patient, doctor-patient. It should be really a mutual relationship going both directions between patients and their caregivers and the doctor and the care team on the other hand. Personalized care plans for the survivors are very important together with AML treatments. As I showed you, let's say if we know that patients who have lots of cardiac trouble before going to treatment will suffer more, why don't we try to fix that before even initiating the treatment, or have a very dedicated plan to manage it alongside the treatment of AML. Prospective studies are needed to define those vulnerable patients, focusing mainly on older adults. If we treat a disease that half of patients are above 60, we really need to do more and not just having studies in those who are fit and less than 50, let's say, including PROs or patient-reported outcomes as a primary or secondary endpoint in the studies, evaluating the new drugs. This is the new trend now, and it will continue to grow, will continue to be better defined. So I will not be surprised in the future if we see a drug that's very effective, but again, it doesn't gain approval because it might be very toxic, or patients really reported miserable quality of life on this drug. So it doesn't make sense to give it. It's not yet there, but this is very evolving. So these are some resources which you might find helpful about survivorship and what really to do, when to seek help, and what kind of help you might get. It's mostly in the States, but this is Penn Medicine, and this is ASCO, or American Cancer Society, and this is from Seattle, for mainly for survivors of transplant, and I hope you might find it helpful. With this, I will really thank you so much for joining us on a Saturday morning. I hope your rest of weekend really goes very well. And I'd like to thank the Leukemia Lymphoma Society for this great initiative and for inviting me. And I'll be happy to take your questions. Thanks.
Thank you very much, Dr. Elsawy, for sharing your experience and your expertise and your insight with all of us this morning. So we're now going to move over to the question and answer period. So if you haven't already had an opportunity to do so, please use the Q&A box on the Zoom webinar panel to type out your questions for Dr. Elsawy, and we'll do our best to get to as many questions as possible this morning. So Dr. Elsawy, we do have a couple of questions that have come in thus far. One of the questions we have are, what are the most common types of comorbidities people with AML experience?
Oh, that's a great question. So it's really very variable because I think you mean post-treatment, if I understand correctly, not before treatment. And from our experience, really fatigue or tiredness is the most common comorbidity, or let's say health issues that patients experience after the treatment of AML. If they get to transplant, this might be even more pronounced with other health issues, in particular cardiac health issues, because some of the treatments are really toxic to the heart, and it might take years before this impact happens. For those who receive transplant, something called chronic graft versus host disease could be a major comorbidity after transplant, which could really trickle in for years.
Thank you. And you mentioned fatigue there in your answer. So another question that came in actually had to do with fatigue. We've all, I think, seen and experienced an increased level of fatigue during the pandemic. So have you seen fatigue present more severely during the course of the past 16 months? And if it's showing up stronger right now for our patients who are battling AML?
It makes sense. Again, that's a very good question, that fatigue levels are increasing. We didn't really measure it systematically, so I cannot really comment objectively on how. But in general, and I could tell you even across the board in other diseases, not just acute myeloid leukemia, because we do lots of visits over the phone or virtual visits. Patients, yes, they do express like a decreased level of energy. I don't have much energy. We don't used to go out and about as previously. So it does impact, like this whole pandemic did impact the level of activity and the level of energy patients are having just because they had to stay home. So I agree, there is an impact, but it's interesting that this is not yet measured systematically. But I do agree, it is there.
Thank you for that. So we have a couple questions, Dr. Elsawy, coming in around research for AML and what maybe the difference is between research for children with AML and where that's at right now in comparison to the research that's being done to treat adult patients.
So again, that's a very good question that really reflects an insight on the treatment itself. So treatment of AML is very intense. So when you look at pediatrics and being able to practice some pediatric leukemia in the past, pediatric patients really have lots of resilience and have lots of reserve, let's say, in their bodies that allows researchers to intensify the treatment more and more, and patients usually bounce back. So they do respond well, but with no excess morbidity or mortality, let's say, from the toxicity of treatment. That's just due to the nature of pediatrics. They have lots of organ reserve. They don't have lots of comorbidities, if ever, other than their leukemias. Now, when you get to an older adult, just having 65 or 70 years old, that puts you automatically at risk of less body reserve in terms of organ functions, maybe with some other diseases, diabetes, high blood lipids, or hypertension. These factors by itself makes really intensifying the treatment very challenging, because you have to balance the efficacy with the toxicity. So you don't want to have a treatment that's very efficacious, very intense, but very toxic in the same time. So really the net gain is zero. That's one difference. The other difference is that pediatrics usually have lots of different techniques in doing transplant that we don't use for several reasons. We are not going through the technicality of that, but that makes their outcomes slightly ahead of us in general, even in treatment of other cancers, mainly because of the resilience really and the bouncing back of pediatrics. So they can intensify treatments that we cannot really do in our adult patients.
Thank you. So we have some questions around life expectancy. So what is the life expectancy of an older adult who's been diagnosed with AML or ALL versus a younger patient?
Well, in general, younger patients tend to have more life expectancy. That's uh, just very broad and I'd say very less precise answer because simply there are more chances that they will get more and more intensive treatment and let's say transplant. But when you go, you have to really look at the specifics of the disease itself. Now, AML is not one disease. I could have a patient with AML who's young, healthy, 30 or 40, but really very aggressive disease, very bad molecular markers, didn't respond to treatments. Outcome would be really very unfortunate compared to an older adult with an indolent type of AML, very good molecular markers, some targets which are available, drugs available for some targets, responsible to treatment. So it's not really comparing apples to apples. I cannot say like AML like in an older versus a younger. In general, yes, but you have to really look at the specifics of each patient's disease, and then you can tell. It's not one size that fits all anymore. It's very heterogeneous. AML is not one disease. I didn't mention that, but it's really many subtypes. And if you look at the algorithm which I showed you, we used to have one treatment that fits all. Now you really have to sit down, look at all the molecular markers, cytogenetics, before you even think what kind of treatment will be best for this particular disease.
Thank you. So one of our questions that's come in would like to talk about the risk of recurrence when you've completed your treatment for AML, and if after 2 or 4 or 6 years, if the risk of recurrence changes.
Yeah, so this question we get very commonly, and it's a very valid question. So in general, and this is again without going through the specifics of transplant versus no transplant, most of recurrences, if it will happen, it will happen within the first year. So as time goes by, recurrences happening becomes less and less. So let's say this is again totally arbitrary, but like let's say maybe 70 or 80% of recurrences, if it will happen in the first year. And this reflects on our follow-up. So during the first year, we do like monthly blood work, follow-up every 3 months, because that's when we know most of relapses. If it will happen during this time. As we move forward, we feel more and more reassured. At 5 years, relapses really are very rare. We could say like at 5 years that represents a cure, but as time goes by, as years go by, chance of relapse gets less and less.
Thank you. So we have just a couple more questions here and then we'll wrap up. So this is kind of on the future of treatment, and you touched on this some during your talk, but what would the options be like for somebody today in 2021 currently with AML when it comes to CAR T-cell therapy?
Not on a standard of care, so it's not yet even on advanced clinical trials. Most of the trials are still very small. Results are promising, but for AML in particular, it's very challenging because in contrast to ALL and lymphoma, those CAR T cells, as I told you, they need a target to identify on the cancer. For lymphoma and for ALL, we do have a consistent target called CD19 that all the lymphomas, virtually all of them, and all the acute lymphoblastic leukemias express, so you can train those T cells to identify this specific target, go and destroy. For AML, again, because it's very heterogeneous, there are many targets. So if you train them to target one target on the cell will easily lose that and then develop another mechanism to hide that target, develop other targets. So it's very heterogeneous, as I told you. This is just one factor. So it's still, I'd say, in its infancy, but in AML, but coming fast. So don't be surprised if in like 3 or 4 years we'll have a trial here in Atlantic Canada, but it's lagging behind compared to, in contrast to lymphoma and ALL, but coming, but not today for sure.
Sounds good. The future of tomorrow. So we'll move on to our final question. If there's any other questions last minute that are out there, please feel free to put them in the Q&A chat box there at the bottom of your Zoom webinar panel. But we'll get to the last question we have for now, which is in the future. So speaking of the future of AML treatment, do you feel that stem cell transplants will be used as much as they are currently now for treatment of AML, or do you predict that we'll see new therapies that will replace that?
That's again a very futuristic question. As a transplanter, and I'm a transplanter by default, so I do lots of transplants, I don't see transplant is yet vanishing in AML. I'd say transplant techniques will differ because even CAR T is a transplant. It's a transplant modality that uses a different technique to do a very specialized, very personalized form of transplant. So that's transplant. So I see the techniques of transplant like preventing GVHD. We have a trial that is looking, it's pan-Canadian trial, hopefully will be very positive trial, looking at preventing GVHD, whether we could do better by using old drugs in a different way, kind of teaching an old dog a new trick kind of thing. So transplant will still be there, I think will never be out of the equation, but outcomes and transplant modalities and techniques will differ. Now with lots of maintenance therapies and lots of targeted therapies, yes, it might be like decreasing a little bit, but I wouldn't say it will be one day like not existing for AML. I don't see this happening, at least in the near future.
Thanks for that. Thanks for looking into the future for us, for some feedback this morning. So thank you again, Dr. Elsawy, for joining us this morning. We really appreciate you taking your time to present on this really important topic. And we'd also like to send a thank you to Astellas for generally supporting this event for our community here in Atlantic Canada. So I'd like to remind everyone that we are definitely here to help you. So please do not hesitate to contact the LLSC if you need more information or support. So our information is there up on the screen, but you can reach us by email at info@bloodcancers.ca or toll free at the 1-833-222-4884 phone number. Also, we encourage you guys to check our website regularly to watch all of our past webcasts we have on a variety of different topics, or for dates on our upcoming webcasts that are like this one. A note that a short survey is going to be sent to all of our participants following this webcast, and we would really greatly appreciate you could take a moment out of your day to fill it out, as it will help us offer you the most valuable information in the near future. So thank you again, everybody, for joining us on a Saturday. Thank you, Dr. Elsawy. We hope you all have a wonderful day and that everybody stays safe. Bye.
Thank you so much, Aline. Thank you, Trudy. Thank you for our patience. Thank you, Charlotte and Sonia, for supporting. And you guys enjoy. Happy rest of your weekend.